Welcome to our presentation on dichloroacetate sodium and its effectiveness as an alternative to treating cancer. This presentation will discuss its mechanism of action, the cancers it has been shown to treat effectively, and discuss some of the many research that is currently available. Dichloroacetate sodium, also known as DCA, is the sodium salt of dichloroacetate acid. It is also a byproduct of water chlorination. We will begin our presentation by discussing the mechanism of action.
One of the phenomena noticed in cancer cells is the metabolism shift from oxidative phosphorylation, usually utilized by normal cells, to using the glycolytic pathway instead. This is termed the glycolytic switch, and when it occurs even in the presence of oxygen, then this entire phenomenon is termed the Warburg phenotype or effect. Though there has been no causal significance about the propensity of a cell to become carcinogenic with this phenotype, it has been shown that it creates acidic environments which promote angiogenesis and thus metastasis of cells. By having this mechanism, cancer cells increase proliferation and thus DNA synthesis. DCA, dichloroacetate, works to inhibit tumor growth by inhibiting the pyruvate dehydrogenase kinase, which inhibits or rather prevents the regeneration of NADP plus that these cells use in order to continue utilizing the glycolytic pathway to make ATP. By shutting this down, this effectively switches the metabolic pathway of the tumor cells from glycolysis to more of the oxidative phosphorylation, which then leads to inhibition of the tumor growth.
So far, DCA has been used to treat a variety of cancers in research studies, one of which is acute myeloid leukemia. In 2016, a study showed that DCA was able to inhibit pyruvate dehydrogenase kinase 1, which is an important enzyme in aerobic glycolysis that is expressed in high concentrations in solid tumors. So by inhibiting this enzyme, DCA was also able to inhibit cell proliferation in cases of acute myeloid leukemia. Another cancer that has been studied is non-Hodgkin's follicular lymphoma. In 2007, a case report was submitted where a man with stage 4 non-Hodgkin's lymphoma with a history of unsuccessful chemotherapy treatments was administered 900 milligrams of daily DCA for 4 months. And after 4 months, a PET scan revealed complete remission of his cancer that continued with daily maintenance dose of 750 milligrams of DCA with additional B1 supplementation. The drawback of this study, however, is whether or not discontinuing DCA may result in recurrence of the cancer. So more studies are still needed to support or deny this particular study. Another cancer that has been looked at is ovarian cancer. One study showed that DCA was able to induce apoptosis and reduce oxidative stress enzymes, as well as increasing superoxide dismutase in epithelial ovarian cancer cells. And these particular types of cancer cells are prevented from undergoing apoptosis because they're under intrinsic oxidative stress. So by increasing intrinsic antioxidant status, the cancer cells were less likely to survive. Other cancers that have been studied with treatment of DCA is breast cancer, colon and colorectal cancer, glioblastoma, lung cancer, carcinoid type, neuroblastoma, oral squamous cell carcinoma, and prostate cancer.
Next, we will discuss the different delivery methods and dosage protocols that have been researched in regards to treatments using DCA. There are 2 different delivery methods for DCA, intravenously or orally. Intravenously seems to be the preferred delivery method because of absorption and therapeutic availability. When dosing an IV protocol, you can go up to 100 milligrams per kilogram based off the patient's weight. However, many are started around 20 milligrams per kilogram and dosed up depending on tolerance. Since safety and efficacy are still being researched, most will stay around 50 milligrams to 70 milligrams per kilogram for a patient. The DCA would be injected into a 250 ml sodium chloride drip bag and administered over a 45 to 60 minute time period. You would receive the IVs twice a week. Some people also add in high-dose vitamin C or glutathione IVs or pushes for neurological support during treatment. The second delivery method is orally. Orally, you would start out at 10 milligrams per kilogram and dose up to 25 milligrams per kilogram based on patient's tolerance. If the patient experiences neuropathy, you would decrease to the dose below where the neuropathy first began. The patient would take half the dose in the morning and the second half in the evening. You would do this daily for 2 weeks and then take 1 week off. There are some sources that say to empty the capsule into water and to drink the DCA powder. This is better for absorption. In addition to the aforementioned high-dose vitamin C and glutathione supplemental treatments, there is anecdotal evidence that shows there is some synergy with DCAs taken in addition to caffeine. Typically, patients would drink black tea throughout the day. There has been anecdotal evidence to show that it is effective for patients that drink 2 cups of black tea all the way up to 10 cups of black tea throughout the day. Vitamin B1 or thiamine also helps reduce the chance for neuropathy and can be taken in a dose between 500 to 2500 milligrams per day. Interestingly, it has also been shown that procaine, diclofenac, or sulindac, which are NSAIDs, help also increase the effectiveness of DCA. Omeprazole, dosed at 80 milligrams per day, also can increase its effectiveness. We will now take some time to discuss some of the research that is currently available on using DCA as an alternative cancer treatment. One such study looked at glioblastoma. Glioblastoma is the most common and malignant primary brain tumor currently. Glioblastoma cells rely on both glycolysis and mitochondrial oxidation. The homeostasis of energy metabolism of glioblastoma cells might be disturbed by dual inhibition of glucose metabolism. So this study aimed to target the pathway by using DCA in combination with a mitochondrial toxin. Individually, both the mitochondrial toxin and the DCA induce proliferation arrest in the cell lines. However, together they work synergistically and inhibited cell proliferation, which impaired the clonogenicity and induced mitochondria-mediated apoptosis. However, there was no significant effect on non-cancerous cells.
We also have an additional study showcasing the effects of DCA on the treatment of endometrial cancer. A 2008 study in the Journal of Gynecological Oncology showed that DCA was able to reduce endometrial cancer cell viability in a dose-dependent manner through the promotion of apoptosis while having no effect on non-cancerous cells. It was able to inhibit endometrial cell or cancer cell survival through multiple molecular mechanisms, including the regulation of mitochondrial membrane potential, intracellular calcium levels, loss of survivin expression, and PUMA induction.
In a meta-analysis evaluating dichloroacetate as a potential metabolic target in cancer therapy, they evaluated the proposed mechanism of DCA to inhibit pyruvate dehydrogenase kinase and shift the polarity of mitochondria. Basically, this means that they were evaluating DCA's ability or proposed ability to shifting cancer cells from using the glycolytic pathway to instead use oxidative phosphorylation. In this study, this meta-analysis, they xenografted non-small cell lung cancer into 2 groups of mice, one of which was treated with dichloroacetate and the other which was not treated with anything. In the mice that were treated with DCA, they had greater survivability, and it was shown that the mitochondria were reactivated and thus causing increase in reactive oxygen species inside the cell, allowing for apoptosis of those cells to occur. Even though you had a shift from glycolysis to oxidative phosphorylation, DCA did not create any adverse effects on the normal cell tissues. In other studies that this meta-analysis evaluated, there was a non-randomized placebo study in small cohorts of patients that have mitochondrial diseases. Primarily, the one evaluated was mitochondrial myopathy, encephalopathy, lactic acidosis, and stroke-like episode syndrome, for short MELAS, which showed that there was an increase in neurotoxicity, primarily peripheral neurological symptoms that resolved after discontinuation of DCA treatment. Now, in these conditions, there is an increased risk for peripheral neuropathy, and so the neurotoxicity that was observed, it's hard to exactly delineate if it was just the normal progression of the condition that was exacerbated by the DCA, or if the DCA primarily was the cause. Because this is a meta-analysis and there have been other placebo-controlled double-blinded studies done on DCA's ability to shift the metabolic pathways of cells, this treatment is considered a level 3.
As of right now, the strength of evidence that is available regarding the treatment of cancer with DCA is ranked at a level 3. And also, as of right now, DCA is not legally available as a drug or a supplement within the US other than through clinical trials. However, it is considered an orphan drug.
The research on DCA and its ability to be helpful in cancer therapy is quite promising, because the research that we've seen has shown that DCA has been beneficial in non-small cell lung carcinoma, non-Hodgkin's lymphoma, endocrine cancers such as breast and prostate cancer, just to name a few. However, for all of its positives, it is still just a level 3 in terms of evidence, and additional research is warranted in order to fully comprehend the dosing necessary for the cancer type as well as the staging of the cancer that the patient might experience, the safety parameters because of the toxicity noted in patients with MELAS, as well as the efficacy of it. Each cancer is different. There are many different oncogenes involved, and the parameters for its effectiveness need to fully be understood. So based on this, our recommendation is additional research, especially since the FDA sees it as an orphan drug, which basically means that they have not recommended it as a cancer therapy. So before they can feel comfortable, I believe that additional research would be beneficial, and a cohort study should be the next step to follow those patients who have been treated with it, and to do a large clinical trial with this therapy. DCA is a readily accessible compound that is a byproduct from chlorinating the waters, and so that's another concern as well.
On the next 2 slides, you will find a list of all the references mentioned in this presentation. They are all hyperlinked for your review. This presentation was presented by Celeste Richmond, Gaynell Nave, and Dorian Richardson, all 4th-year medical students at Southwest College of Naturopathic Medicine in Tempe, Arizona.